HIV. We also have Bob Silicano is on the schedule for later this year, in the spring, a little bit closer, to give us some more updates on the work coming out of his lab and our understanding of the HIV reservoir. And please feel free to send me any suggestions you have for topics that you would like to see. We'll have cases again in the next couple of weeks. So now today, without further hesitation, I am really excited to introduce Dr. Heidi Hutton, who I have just learned is actually based in Boston, but is here in the Department of Psychiatry and Behavioral Sciences, and has done an amazing amount of work on people living with HIV, interventions with substance use disorder, and how to achieve that thing that no one can achieve even in our own lives, which is behavior change. So I asked her to come and talk to us about motivational interviewing, and Dr. Hutton, it's just really a pleasure to have you.
Thank you. I feel like I know so many people because I spent almost 30 years working in the Moore Clinic and then Bartlett. And then I was thinking of the list today, and I realized I have worked with Larry Chang on 2 projects in Uganda on HIV and uptake into care, with Gitanjali, of course, Chandra, my colleague of 20 years. We've done several projects, person and computer-delivered MI projects, and Shona Falade and Vivian Go, who's now at University of North Carolina, 3 projects in Vietnam that used MI. I actually made a list, and Kathleen Page on a project of training her health workers. And then we have a computer-delivered project with Jean Clark, that uses MI to reduce smoking in housing projects or housing units. So there's several places in which I've been involved with people. I'm going to share my screen now, and what I'm going to do is talk about, this will have a few parts, which is talking about generally about what MI is about, and teaching you some core skills, and then also how we've taught MI. And I will run through my slides pretty quickly. Let's see. So can you see the full slide, or are you seeing the slideshow, or are you seeing?
That looks perfect.
Okay, great. Okay, so I want to give you a little bit of background, which is that originally, back in the 80s, the alcohol treatment was seen as advice and warnings were issued in the therapeutic context, until these 2 psychologists, William Miller and Steve Rolnick, decided, literally, I think the story goes that they were in a bar sharing a beer, deciding how to rework treatment for alcohol use disorder. So MI came out of a substance use disorder, particularly alcohol background. And they decided that they need to totally upend, create a new paradigm for treatment, and reset our understanding of alcohol, the genesis of alcohol use disorder. That it wasn't that it was an unmotivated problem drinker or the person who has a failure of willpower, but it was really about a failure of, not a failure, but people were not ready for change. So motivational interviewing, I want to emphasize that it's collaborative, it's goal-oriented, but it's really a style of communication. It's not theory-based. It's not a method like cognitive behavioral therapy or some of the other work that comes out of my area of the world. It's really about enhancing the person's motivation for change by eliciting and intensifying their reasons for change. And it relies very much on the use of empathy and non-judgment. So I think we've all had the experiences of providers where we get in that trap of advising people on what they need to do to change, and we actually tend to strengthen the person's commitment to the other side of the equation. And of course, we're well-meaning, but it's when we take that approach, we often limit our effectiveness. So MI comes from the idea that there's no one that's unmotivated. It's just that people are just not ready to change, and that every human behavior is ambivalent. Even though it might be 1% in favor of changing or reducing alcohol use, and the other 99% loves drinking and doesn't want to stop, there's still an ambivalence there. And so our job as providers is to tip the scale of that ambivalence in favor of change. So, but importantly, there are underlying values to MI. It's called the MI spirit. And I've dedicated a whole slide to this because if we don't embrace these core values, and values aren't talked about that I'm aware of in other aspects of behavioral interventions, or we have our values, our core ethical values in our various disciplines, but this is the only intervention that actually talks about spirit and values. And it's very important, and it's so central to the delivery of care with MI. So it's follows this acronym of PACE, which is partnership, it's collaborative. So it's very important that we become the experts in behavior change, but we're not the expert on the client. And that is, I think, one of the biggest paradigm shifts with MI. And so you come together in this collaborative relationship where both people are experts in something, but not on each other's areas. So second is acceptance. Now, what's important about acceptance is that it's not about agreeing with what the patient does, or agreeing with their decisions to change or not change, or their engagement in behaviors that are not productive for them. But it is about acceptance and understanding their perspectives. It's the third one, of course, is compassion, it's empathy. It's not sympathy, but it's empathy, and truly trying to understand what the person's own needs are. And finally, it's about evocation. And I think evocation is really it's a very important core value, because the idea is that you draw out the person. Your job is to discover what are their priorities, what are their values, and you're going to harness these in the service of behavior change. And often, and I put a little example there, it's about developing discrepancy. So when the person says, I want to exercise more, the example I cited there is, you said that it's important for you to exercise more. How does that tie in with your smoking? So that creates a discrepancy for the patient. And then you open up the discussion about, which is more important to you. So that's an example of evocation. I'll get into a lot more examples, but if you take a few things away from this time that we have together, the MI spirit is really critical. And and it actually bears out in the research on outcomes using MI. Okay, so the current status, it's amazing what's happened with motivational interviewing. It came out of the treatment for alcohol use, and now it has exploded. There's no other word for it. It's been used in HIV, as you know. I'm using it on a lot of HIV projects, hypertension, IPV. It was very widely used in vaccine uptake, obesity, substance use, diabetes, exercise. If you do a Google search, it's applied to so many different behaviors. And it's also spread globally. And I think the reason why it's had a global application is that motivational interviewing is fundamentally humble. It doesn't place the US researcher as the expert. And so the acceptance and the uptake in the different countries I've gone to, Uganda, Vietnam, and India, has been excellent, because we're not coming in as the expert. There's the understanding that it's collaborative, that everybody is an expert in the niche that they are accessing. So if you look now to outcome studies, there have been about 1,400 RCTs and 150 reviews on the effectiveness, mostly substance use, but as I say, it's certainly expanding. And if you look at meta-analyses, in my world, not in your world, but in my world, a small to moderate effect size is huge, because behavior change is so complicated in humans. And very difficult to measure and always mitigating factors. But it's interesting because that's actually a good outcome. I'll show you another slide in a moment. But what's also helpful about MI is that these studies that were done in these systematic reviews, the interventions range from 15 to 480 minutes and usually 3 sessions. Now, 3 sessions is extremely cost effective. And that may obviously for other psychiatric disorders that may not be sufficient. So I'm focusing on behaviors. What's interesting is that these changes that are made after motivational interviewing interventions are applied, that they're pretty durable up to a year, and in the alcohol use research, it's durable up to 5 years, which is pretty impressive. So this slide, I'm sorry, you can't probably see it that well, but you can see that there are, this is a binomial outcome, but it's, you can see that for certain, there are marked effects for substance use and physical activity, body weight, not so effective for eating disorders and self-care. And by the way, these are outcomes that are not just patient-reported outcomes, but also third-party outcomes. I will tell you too that, for example, in our Vietnam intervention, which was alcohol use in HIV clinics, and we had compared MI and a cognitive behavioral intervention with usual care. And not only, it was self-report on reductions in alcohol use, which the treatment group, the MI group, had a greater reduction. But importantly, a year later, the MI treatment group also had higher rates of viral suppression. So there you have a biological outcome, which is always comforting, and of course, what you want to see when you're doing HIV care. So that was pretty exciting. Now, why is what really is the appeal of motivational interviewing? And I think that one thing is that it shifts the onus of the work from the provider to the patient. I find myself sometimes, I mean, even though I'm trained in MI, I will have interactions with patients where I find myself providing advice. And in fact, the more resistant they become, sort of the louder I'll speak about what they need to do to save their life. And I walk away frustrated, and I'm sure the patient is frustrated too. So MI allows you to shift the onus, that it's really, you want the patient to make their own argument for change. You want to find out what the patient's resources are for behavior change. And my job becomes more one of evoking rather than instilling motivation. So it relieves the provider of the burden, and these behavior changes are very hard. So, and it can, patients who don't make behavior changes and you watch them often, and I remember in the early years in the more clinic where the patients would die when they didn't take their medicines, and would die quite quickly. Siobhan, I know you remember those days. So it's scary and frustrating with patients who don't follow the advice that we want to give them. But MI gives you another tool in your toolbox for encouraging behavior change. Anyway, MI is also, so it's evidence-based, it's effective, and comparatively economical, which is, I think, is a benchmark of a good intervention. And it can also be combined with other therapeutic methods. So we've done a lot of work with Gitanjali right now in India. The MI intervention is being used with, and not only with HIV, but also TB patients. And with Larry, it had nothing to do with alcohol. It was all about engagement and the sustainment in HIV care. So it can be adapted. It can dovetail with other cognitive behavioral therapy and other therapies. The important thing is that it has core skills that can be taught. And I've taught it to physicians, psychologists, and community health workers who have had no background. And in the case of Uganda, had perhaps a middle school formal education. So it can be taught, it can be learned, and it can be measured, which is also helpful in studies of MI. And it can be used in medical practices with limited time resources. Okay, so this slide is only to say that MI is not about meeting the patient where they're at. That's a phrase you often hear now. That's a little bit of it, but it's a directive procedure, and there's very definitely a structure to the sessions that you have. And you are moving the patient, perhaps subtly, but you are moving them towards, you engage them, you're going to focus on a problem, you're going to evoke their reasons for change or their barriers to change, and then you make a plan on how change is going to occur. So that's only to say that. Okay, so how to teach MI? First thing is, I always spend time talking about MI spirit, because as I said, that's the foundation. Then I teach core techniques, which I'll talk about in a moment, which goes by the acronym ORS. And it's very important to elicit local input to make sure that the intervention is adapted to your local context. In teaching MI, I try to model the MI values, and then of course, role play is very important. Okay, I'm only going to say about this slide is that I always begin training with the favorite teacher exercise. Who was your favorite teacher? What were their qualities and why were those important? And no matter what setting I teach this in, it's a great icebreaker. The core values, globally, they're all the same. The favorite teachers were the ones who were encouraging, motivating, non-judgmental, caring, basically all your core MI skills. So I just think that's interesting. And perhaps those core values are the reasons that are in the favorite teacher that are in MI, are also the reason why MI has such great global uptake. Okay, so the communication skills, and I'm hopefully we'll get through all of these today, but the first ones are open-ended questions, affirmations, reflective listening, summarizing. It's okay to provide advice. That I think often people say, well, you're not supposed to tell people what to do. Oh no, you can tell people what to do, but you ask permission first, because if you ask permission, and I've never had a patient say, no, I don't want to hear what you have to think, then they've invited you in, and then you can give them their advice. And then you listen for change talk. Okay. So open-ended questions versus closed-ended questions. And if you go home tonight, if you take one thing out of this talk, just try the difference between an open-ended question and a closed-ended question. So when you walk in tonight and you probably see your partner or your friend and you say, did you have a good day? Well, that's a closed-ended question because it's a short answer of yes or no. And it doesn't sound like I often think I ask that question because I'm really just hoping that he's going to say, yeah, it was a good day. That's very different from saying, how was your day? And that is fundamentally the difference between open-ended and closed-ended. One encourages connection and conversation, and the other one shuts it down or gets you a quick answer that's efficient, but doesn't teach you or help you to understand much about the person. So open-ended questions will tell you why people hold the beliefs they do or why they act the way they do. It opens the door, it broadens potential responses, and it encourages the client to talk. Closed-ended questions, we need those. When you sit in the room with patients, you've got to run through your list of questions because you have limited time. So they are efficient, but they may limit your answer options, and it may not be as useful to understand always what's going on with the patient. So some examples of open-ended questions are, what do you want from treatment? A big one that we used during COVID was, what do you know about vaccines? Because people's myths and misinformation about the vaccines were legion. And if you don't know what the person's particular concern is, and you just start in with why they need to get their COVID vaccine, then you've lost them. But if you open with, tell me what you know about getting a COVID vaccine, and you find out, well, they got Guillain-Barré from a Lyme disease vaccine that was given in the military back in, I don't know, it was the 2000s, early 2000s. Well, obviously that person has a good reason. They're concerned about getting a COVID vaccine. Your intervention with them is going to be very different, which you wouldn't know unless you asked some open-ended questions. So others, like if you were to cut down, how would you do it? How did you decide to target, what do you know about AA? So those are all open-ended questions that can encourage conversation. Now, there are some patients, and probably also including ourselves, that if you ask open-ended questions, you're off to the races and they begin, you can lose control of the interaction. That's where summaries come in. I'll cover that later. So here's just, I'm going to sort of intersperse examples, but here's an example. So heavy drinking, you can begin with why it's dangerous for the patient's health and so forth. But if you take just a second with the MI approach and say, what do you know about the effects of heavy drinking? Client says, I don't know any, I don't think it's so bad. Then you say, okay, so right now you don't know any harms of heavy drinking. If it's okay with you asking permission, I'd like to share some information that I have about heavy drinking. That changes the tenor of the interaction. Look, I mean, is it going to change the patient's behavior? No, but you've gotten more information in them without building up their resistance to your coming in with advice and warning, which is borne out by the research, by the way. So how we teach it with, and this really underscores it for people when we teach it. You take 5 minutes and have a client and counselor pair. And we've done this in every setting that we've tested or taught MI. And the person, so for 5 minutes, asks only close-ended questions, which is, okay, this is also a little bit artificial, but you have them ask only close-ended questions. In this case, of a person, the client's pretending to be a heavy drinker with HIV. And, have you gotten treatment? Have you been to AA? Are you taking your HIV medicines? Things that are important to know. But if the ratio of closed-ended questions is very high compared to open-ended, you're going to have a very different sense of the interaction. So you have them record what it's like with the closed-ended, and then you do only open-ended questions. Tell me about your experience with taking your medicines, your HIV meds. How did you begin drinking? What's it been like for you? It's just, again, open-ended questions. And then you have people note how they felt. And what people will say is that closed-ended questions feels kind of like a machine gun, is what one person said, or like they're being interrogated, or the person asking the questions doesn't really care. They're just trying to get through the list. Whereas in open-ended questions, both the client and the provider say that they feel like they have a better understanding of the client. It feels more humane, that in fact they gleaned more important information that was specific to the client so that they could then tailor their approach. Okay, so that's how we teach that. Sorry if I'm going through too fast, there's a lot to cover. So affirmations, what I love about affirmations is this, and I'm going to sort of get to the punchline before I actually get to the definition. Affirmation is identifying the strengths of the client, and that is used to build change. Now, the reason why I like affirmations is that the whole purpose of MI is to build the client's strength and resources for change. It's not about you as the provider. So if the client, I'll give examples in a minute, but it's, simple positive statements. It helps the client believe in themselves. If a client leaves my session and I haven't mined for some strengths on the part of the client, then I feel like I haven't done my job. But what I really like about it is that they are different from compliments. And if a client comes in and said, I've been taking my medicines every day for the past 3 months since I last saw you. And you say, great job, that's wonderful, which is what we all want to say because it's great that they're doing that. But the problem is when you provide a compliment, you are also providing a judgment. So you can bet that the next time that they come, they're scheduled to see you, and they haven't been taking their medicines, they're either going to come in and obfuscate what their pill taking was in the past months, or they'll skip the appointment. So compliments are judgments, and MI is not about judgment. MI is about non-judgment. So it's far better in MI, well, it is MI. But I find it's far better to say to the person who comes in, you can still express joy about their taking their meds or reducing their alcohol, saying, you must be really happy about that. What have you noticed that has changed as a result of reducing your alcohol use or taking your medications? How do you feel about yourself in making this change? So you can still participate in the patient's pride, but you just take yourself out of it as a relaying a compliment. You're not the judge. Okay. So general affirmation examples often begin with, it's important to you that, you value that, you tried to, you've survived a lot of difficulties, taking care of others is important to you. I always keep the phrase in my head, it's important to you that, because I'm always trying to figure out, what does this person value? What matters to them? Because then I can leverage that into helping them make changes. So when they say, I'm not taking my HIV meds, I'll say, you told me a few sessions ago how important your kids were to you. How do you put the importance of your and love of your kids with not taking care of your health? Again, setting up that discrepancy where they're forced to see both sides of the equation. But I'm not doing it. I'm just setting it up for them. I'm taking their words and their situation and asking them to think. I'm not telling them what to do. Okay, here's a couple of examples. So I'll tell you one. I had a client, if anybody in the old days in the Moore Clinic remembers that the wait was so long to see people, especially for psychiatry. And because felt like we were always on, everything was urgent. And I had a client who waited a couple hours, and somebody did go out and say, Mrs. So-and-so, Dr. Hutton has been tied up and she's got an emergency or whatever. And man, she was so angry when she saw me. I mean, I just heard it when I finally went out to get her. I just heard a blue streak, and I thought to myself, okay, what am I going to say here? Because I was feeling pretty put off knowing how hard I'd worked that afternoon. And I thought, she just needs to know that I understand. So I said, wow, it took a lot for you to get here. It was raining that day. I said, it took a lot for you to get here. It was really important that you came today, and you came even in spite of the rain. Well, all her anger evaporated. Why? Because she felt heard. I found a strength. Her treatment was really important. She was mad because her treatment was important, and probably she felt like I wasn't valuing it on my side. So it's a way affirmations are not only about finding the strengths in people, but it's also a way that you can diffuse difficult situations. Okay. What we do, the challenging clients are always the ones that perhaps are the most the ones that can drain energy or have us feel sometimes maybe a little bit impotent about delivering treatment. And everybody runs into them, and it's always a challenge. So what we do in training people is to take a sample when we talk to people, like, what's your most difficult client, and try and figure out what are the strengths in that client. So somebody who is, it's easy with people who are cheerful clients, but so a client who doesn't want to doesn't believe that medication is going to be helpful to them. Perhaps an affirmation to them is, you're someone who's very discerning, or you're very careful about making decisions. You don't just accept what the doctors tell you. You really like to think this through. So you first do a strength, and then you think, oh, okay, so I'm going to harness that. If this person is not easily persuaded, then let's use that as a tool. Like, what do you need? What to the client? What do you need to feel better about taking medication? What is possibly what would convince you? So it's taking that resistance and turning it into a strength and harnessing the strength in the service of behavior change. Okay. Now reflections, which is the R in ORS. And obviously I could say a lot more about all of these, but I'm trying to give you the short version. Reflections are perhaps the core skill in MI, and really the most difficult to do. And I encourage you to try those as well at home, and affirmations. But reflections are about careful listening to what the person is really saying, and offering it's a deeper conjecture about what they're feeling or what they're thinking. And I love this quote by Simone Weil, who was a 20th century French philosopher, who said that attention is the rarest and purest form of generosity. And I love that, because that really, which is to say that MI spirit has, a lot of the philosophers talked about MI spirit way before Miller and Rolnick. But, and I'll give you examples of reflections in a minute, but it's essentially you're reflecting back what the person said. And it shows to the client that you're listening and that you understand. It gives them an opportunity to hear their own words, whether they're harsh or helpful or kind. It's that mirror. Yeah, so I'll skip to the next one. So if you listen and reflect, the other person feels understood. When people feel understood and not judged, they're more likely to be able to examine their behavior. So types of reflections. There are the simple ones, and then I'll give you some concrete examples, but there are the simple ones, which are just repeating and rephrasing. A person comes in, I'm sad. And you can say, a simple reflection is, you're feeling really down today. Now, in that moment, that simple reflection, it tells the client, the patient, that you have stepped into their pool, stepped into their stream, so to speak, and you're with them. So it demonstrates collaboration, it demonstrates listening in powerful ways that we as providers often can't even understand. And then there are complex reflections, which I'll show you next, which actually moves the person towards change. So let me give you an example. The patient comes in and says, my father was a bad man, and talks about that. And by the way, well, anyway, come back to that. So a simple reflection is to repeat back, father was troublesome, he was hard on you, so on and so forth. But a complex reflection, which I really like to use when I can, is to promote change and to say, you wish your father had been different. Now, saying that moves the interaction to a whole nother level, because then you can begin to get into, well, what did the patient really want from his father? How would the patient be different when he becomes a father? And you begin to get at the values. The other thing is that if you only reflect, my father was a bad man, yes, your father was a bad man, or he was a difficult guy, or whatever, then the patient can go into this sort of down the rabbit hole about negative feelings. And obviously that's something we don't want to encourage. So you do want to move the interaction along and say, that's where complex reflection comes in. So how to phrase reflections? It begins with, it sounds like, which is sort of the classic, now popularized on TV shows showing therapists. So it's a little hackneyed. I try and avoid it because it's too much in the parlance, like meeting the patient where it's at. It's a tired phrase. But you're wondering if, your concern is, you believe, you wish. Those are all the beginnings of reflection. And you can only make those if you're really listening to the patient, unless you're just doing a rote repeat of what they said. But It also engages the provider. It keeps the provider's focus on the patient and interest in the patient. So it creates a tighter collaboration between patient and provider. So why is reflecting so important? Why is this such a foundational skill in MI? And the reason is that of all therapeutic factors that they've studied, empathy is the most consistently related to positive outcomes and behavior change. And reflections are a way for you to use to harness empathy in the service of behavior change. Obviously, more than 80 independent samples representing more than 6,000 clients shows a moderately strong relationship with client outcomes. By the way, what's really interesting, so Gitanjali and I have a computer-delivered intervention with an avatar who we created based on a lot of sampling of avatars. She's a woman, sort of mixed race. She's a provider in an HIV clinic, and we taught her how to do MI. So when the client, the study participant enters a response, she responds back with MI. And you find that avatars who are MI trained, that there's a greater connection between a client and the avatar if they use MI than if they're just doing straight advising or warning or reassuring. So it's interesting how it plays out. I think I read, our brains aren't sophisticated enough yet to process the difference between a person and an avatar. So the same area of the brain lights up, whether it's an avatar or a person, as they go through these interventions, which is kind of interesting. I'm sure we'll evolve out of that. But anyway, I just find that fascinating. So it works even in computer-delivered interventions. Now, it's also, MI is strongly associated with medical patients' satisfactions with their physician. And this is important, even if they have a long wait. So that's important for us in busy clinics. These are some, I'm going to skip to the next slide. So these are some sample responses of reflections. So this is the writing is a little bit small, so I'm going to look at this screen. I can't keep my doctor appointments because I can't get to the clinic. Sounds like you have difficulty getting to the clinic. Tell me more about it. I'm not going to read all these, but just sample ones. People don't understand how hard it is for you to come to the clinic, and that's frustrating. So it's responding to what the patient is saying, and you're always thinking in your head, how am I going to get to the next you're listening, but also thinking ahead. I know alcohol isn't good for me, but drinking helps me relax. So on the one hand, again, doing that, developing discrepancy, magnifying the ambivalence, or highlighting the ambivalence. So on the one hand, you're saying alcohol can feel like a good way to calm down, but on the other hand, you're also concerned about the effects on your health. By the way, this is a nuance, but you always end on the positive note. So you always, when you have a sentence with two stems, you always put the positive stem at the end to emphasize that. What else have you tried to feel relaxed? What's worked for you in the past to relax? So these are open-ended questions plus reflections that allow you to explore what's going on for the patient, allows a collaboration with the patient, shows that you're listening, you're working with them, and fosters a better working relationship. How about if someone says, I don't have a problem with alcohol? Alcohol is not a problem for you. Sometimes you magnify the other side of the ambivalence. Or your drinking is not something to be concerned about, so you're not sure that coming here is going to be helpful for you. And then tell me about that. Then they talk about how they've had a terrible experience in other substance use treatment clinics. So and then the next question from you as the provider is, what would you like to have happen differently here? So again, moving them towards fostering change, positive change. Just in a few simple questions. Here's an example of a difference, and I'm not going to read the whole slide, but just highlighting the difference. And it's not that warning and advising are not the right way to go. They're perfectly good approaches. All I'm arguing for here is that before you come in with advice or reassurance, particularly advice or warnings, is that you ask permission first, and then you ask the person after that, how did it feel to get that advice? So I get so shaky and anxious, I have to have a drink before I leave home. It's it's true what the provider says. It would be good not to drink. It would be good to drink less and not start the day with that. That's true. That's not a good way for the patient to start the day. But you might want to begin with alcohol helps you to settle your nerves. Well, tell me about that. So you open up with a more exploratory, non-judgmental question. Patient says, I'm not an alcoholic. I just get that way in the morning. Provider switches into, how much would you say you drink each week? Just an estimate is fine. Obviously, the provider is concerned about their alcohol intake. It's a well-meaning provider. They want to understand how much harm the patient may be doing in their drinking. It's not like it's a bad question, but it's not going to elicit the kind of working relationship that you're going to want to have with your client. So an MI response might be, what's happening with you is not about a label, it's something else. So it's a reflection. The person is very concerned about being labeled. And I think the underlying meaning is that it's not about the drinking, it's really about the anxiety. Okay, I'm going to move on. Those are just samples. This is an exercise that we just use then to, excuse me, to pull those skills together. Again, we do a lot of role playing in MI because you have to, quote, almost sort of feel the difference. You have to experience kind of in vivo what the difference is between MI and other approaches. So we have people use only, pair into group and to break up into pairs and use reflections only versus just a standard interaction with a client and provider relationship. And then after a few minutes, you switch. And what you'll find is that people consistently report, again, across cultures, urban, rural, that the client experience and the counselor or provider experience is far more positive. They feel like client feels better understood, more capable of asking questions, and it's a happier experience for the provider also, who doesn't feel like they are engaging into what could be an argumentative exchange with patients who are not ready to change. Okay. So summaries. Summaries are like my hip pocket method. If you have a patient who talks a long time, or they've gone down or they're angry and getting down the rabbit hole with their anger, summaries are a good way to back things up. They reinforce key points from the interaction, but allows transition. So you can say, okay, so this is so-and-so, what you've told me is that you've had difficulty taking your medications, and you have to hide them because you don't want your family to know that you're living with HIV. And so where do you think what can you think of as a way to take your medicines that will allow you the privacy that you want, but also allows you to take your medicines on time? So they begin with, let me see if I understand what you've told me so far. What we've talked about today is, and then you ask the client, what did I miss? Now, the reason why, what did I miss, is so important is, and this is a subtlety, but when you ask the client to essentially correct you or offer feedback on your summary, you have again created this interaction that is collaborative. It's fascinating to watch. And for those of you, this is a rather unusual application of MI, but it's used in hostage negotiation. It's very interesting. There's, if you guys are, I used to work in forensics, so that's why this is kind of interesting to me. But there's a hostage negotiator that is, I'd say he's one of the not only national but international experts named Chris Voss. And he uses MI skills to communicate with the hostage takers. And all of his work is based on MI principles. And one of them, of course, is that he uses is summaries to begin to forge a collaboration between the hostage negotiator and the hostage taker. It's fascinating. I think it's on YouTube, but if not, you can email me. Okay. So I've got 10 minutes left. I'm going to run through change talk really quickly. Change talk is when the client expresses a desire, a reason, or a need to make a change in their behavior. And it's, we listen for that as we talk with patients because we want to highlight it. And the reason why is that when they looked at mediators of change, they found that patients expressing change talk and the therapist or the provider highlighting it and building on it was associated with improved outcomes across a variety of behaviors. So it's you want to listen to it because you want to build onto it. So clients say, I want to cut down on drinking. So that's the desire. I can cut down on drinking. That's ability. I'm tired of drinking this much. That's the reason. If I don't cut down on my drinking, my wife will leave me. So that's the need. So, and as providers, you can say you're thinking of making some changes. So you want to, sometimes these are just things that patients will just sort of throw off and not even listen to themselves. But the client, the provider who's listening will capitalize on those and go, okay, wait a minute, you're saying that you do want to make some changes, or you feel like you're capable of making changes, or you know, your wife is very important to you and you don't want to lose her because of your drinking. So this is a new thing. This is how are we going to work with this? So that's the it's called DARN. MI is big on acronyms. So that's called the DARN C, and the C stands for commitment. Okay, so change talk, you want to, I'm just going to have you look at the column on the left. What you're listening for is a patient talking about the disadvantages of their current behavior, the advantages of change, their optimism for change, their intention for change. So disadvantages of current behavior. What worries you about your alcohol use? The client comes in, says, I'm only here because I got this a lot because Dr. Chander told me I had to come and talk to you. And believe me, when they come and talk to me because their provider sent them, that's they don't want to be there talking to me. So I would begin with, sounds like you have a really good relationship with Dr. Chander because you came here, that you have a lot of respect for Dr. Chander because you came here because she asked you to. And then they go on and talk about, you know, how great Dr. Chander is, or Dr. Chang, or Dr. Filati, or whoever the provider is, Dr. Baseb, and talk about their connection to them and how important it is to them. And then I can say, so they were concerned about you. What do you think has concerned them about your alcohol use or not taking your meds or your smoking or whatever? So that's how you begin the conversation. And it's always about listening to change. Well, she's concerned about my drinking because of X, Y, and Z. And you explore it with the open-ended questions. But I think you get the point. Is you're trying to elicit change talk in someone who is ambivalent at this point about making a change. Sustained talk is the opposite, and these are tough. So some patient says, I can't, I just can't get by without having a drink. Sorry, these are very alcohol focused, but they apply to other behaviors, obviously. You can magnify the other side, like you can't imagine a life without alcohol use. Oh, no, 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 it's not that bad. Okay, tell me how it's not that bad. So you can, as I say, magnify the other side. Or I've tried the patient who gets sent to me, and I've talked to psychologists and therapists before. So I say, you're wondering how this is going to be different, or you're not sure that our work together is going to make a difference for you. Let's talk about that. So it's about, because I don't know what it is for this patient. And unless I ask those open-ended questions, I'll never be able to tailor my treatment to their needs. These are just changes, how you can see the difference between change and sustained talk. So, yeah, at the end of the day, it's patient's choice to change or not change. We try and, with our collaborative relationship, try and create an atmosphere where it feels safer for them to explore their ambivalence and begin the process of change. I have two questions which I ask people, and I didn't include these on the slides. So there are two ways when you have a patient who is really challenging, there are two questions I ask. One is, where do you see your life in 5 years if you continue to drink, or you continue to not take your medicines, or you continue to smoke? What does life look like then? Now, if it's somebody who's young, like an adolescent, I would say, where do you see yourself in a month if you don't, if you continue to have condomless sex? So the time frames are adjusted for the age of the person. But the one that's really my favorite is asking to the person, when do you know that it'll be time to change? Because you're asking, I'm not advising them to change. I want to know from the patient, what's their benchmark for deciding to change? And they may say, well, it's when my wife says she's going to leave me, or it's when I get endocarditis again, or whatever their benchmark is. So if that does happen, which of course it can happen, then that becomes part of the discussion that you have with the patient is, okay, this was your benchmark. Where do we go from here? It helps for the patient to set the guardrails for themselves, as opposed to my setting the guardrails for them, or the limits for them. It's a very effective question. Try it with some of your patients. Okay. This is a project that we did in Baltimore, but I'm going to skip that and just, this is with Larry Chang when we did actually two projects, but I thought it was interesting because these are Health Scouts. As I said, this is in Kalisazo, Uganda. These Health Scouts that we trained were from this is a rural area of Uganda, had not much formal education, but they were nominated by the local village to participate in this project, because Larry and his team went around and met with the village leaders and said, who would be a person to talk to people about HIV, getting tested, getting into care, staying in care. And that's how the Health Scouts the Health Scout group was formed. But I thought it was fascinating to teach them MI, which was a very different paradigm from what they know in Uganda. They talked about very rigid hierarchies, particularly men and women. And they really took to this approach. And I love that I would talk about MI is that the importance, the eyes are two for seeing, the ears are two for hearing, but the mouth is just one, which is an old expression, but it works in MI, which is do less talking, do more listening and observing. And I love what this Health Scout said. She said, when you're before your client, he's explaining something, you should not interrupt him. You should let him tell you. Watch him with your eyes as you listen with your heart. And I thought that was actually one of the best summaries of MI. I don't know. I kind of tear up whenever I read that, but I cry at movies too. So, but they really embrace the collaborative spirit. When you meet a client, it's if the two of you are educating each other. He shares what you think and you educate him. He'll forego what he thinks because you have not given him orders as if you were but it's as if you were conversing. There were so many, these were all the qualitative interviews after the project. There were so many of these. Now, this is the thoughts from the clients. He's taken his time to come and counsel you. This means this person knows something, and she, the health scout, is concerned about you. She comforts you more than the person who's given you medicine only, which I thought was sort of interesting. But again, this concept of teaching, it wasn't somebody threatening you or forcing you or barking at you. His voice was soft. It was easy for you to decide about something he has told you. So the importance of that. Okay, I got 1 minute. So final thoughts. MI is a way of engaging patients, deciding on what to change, evoking their reasons for change, for making the change. And if they wish, you develop a concrete plan. People, we know this from years of research and clinical work, that people are most likely to change when it's their own decision. Competence and confidence are important in the change, and relatedness and a sense of being supported by key people, including your healthcare professional. Okay, it's 1 o'clock. Thank you all for listening, and I appreciate. I can't take any questions, obviously, but I'm happy to have you email me if. Let's see, I think I stopped sharing.
Heidi, this was amazing. And I think honestly, the best, if we were to have a core group that we're interested, if we could do something in a smaller scale with some workshop, and like, because I have done in the past the role playing, and it's so hard sometimes to get into the role. And just walking through this was reminding me of all the ways I could change a little bit, many of the things I try to communicate. And then the other thing that we'll have to ask you to talk about is what to do when you feel like, with those patients with whom you feel like this is not working, and not from the perspective of like how to hammer at those people, but how to retain your belief and your, like, the equanimity or whatever we're supposed to have when these things don't work. But those are long-winded.
That's a whole nother hour.
Yes.
But there are answers to that. And yeah.
And I think it's the kind of thing that, like, you know, many of us with vaccines, with many of the things that have happened over the last few years, need a refresher in how to respond when people can't take what we're offering.
Exactly. And it's a synergistic process, isn't it?
Yeah.
Because the more they resist, the harder we push the advice, which only increases the other side of the equation for them. Exactly.
Right. Well, thank you so much. And being mindful of the time, I know but I will be reaching out, because as Joyce put in the chat, you know, we have these amazing navigators and nurses, and it would be, I think, a fun thing maybe to do to try to